1, 2, 3. I am losing my voice.
I'll check and see if Shapiro emailed something, because you told him to email me as well.
Yeah.
So while you're talking, I'll
Try to do it?
Yeah.
Okay. You have his email?
well, you copy me.
Yeah, just email him again and just say we need it desperately, send it to me, Douglas, okay? All right, guys, welcome to round 2. I've got 3 talks in a row. Hopefully my voice will hold up. We're going to talk about female hair loss and hair restoration. This is a huge part of my practice. It is something that is vital. However, at the same time, it is an advanced topic. And the reason for this is that male pattern baldness, for the most part, is relatively straightforward with a few exceptions. But female pattern hair loss can be more difficult, both from a history perspective, historical perspective, as well as a treatment perspective. I sort of divide it mentally into unstable and stable hair loss. And unstable means obviously you don't want to transplant that, right? That's a problem. Stable, you may need a transplant, but you need to do some investigative work before you just jump in there and do that. So what are the elements that I'm looking for? These are the points that I'm looking for. So one is, an obvious one, or not so obvious one, is if a woman just gave birth and all of a sudden she has some shedding, is because she's been sustained in an anagen phase from the estrogen, and then it gets released and then she starts to shed. So look at the history. And there's other things, if they've had a prolonged sickness, usually a protein malnutrition in terms of weight loss, general anesthesia, some kind of fever, go and take that history. And that can apply to men as well. There can be some kind of shock loss, traumatic event that occurred beforehand, physical trauma from extensions, product damage, etc. And just look at sort of that whole component of what is going on. From a physical level, what I try to divide it into is into patchy and patterned. Patchy means pieces here and there, but you'll see it's just a term that is it's not global enough, but it's one that's just helpful for me to communicate. And pattern means it's a recognizable pattern, like a female pattern loss. And I'll explain that more in detail here. So, for example, if you've got a circular loss somewhere, don't transplant that. You got to figure out, unless it's like, oh, you know what? If the history and the physical seems to be consistent with it, and they've actually just lost hair from a traction, that would be great. But a lot of times, you think it's traction, they tell you it's traction, and it's not traction, it's something else going on. And you got to be careful with that. So this, you need to biopsy it. And there are ways to biopsy it. I'm not going to go into that. Nicole is going to go over this tomorrow. So again, redundancy is the key to education. And this is sort of patchy. It's basically this loss in the front. It could be traction alopecia, but this is actually a frontal fibrosing alopecia. And that's something, FFA is a big masquerader. I was sent, a friend of mine sent me a patient to operate on. I looked like male pattern baldness. I looked at it and I said, this is not right. And sure enough, it was FFA. And if I had transplanted, it wouldn't have survived. It would have fallen out. So what do you look for? Again, you're going to hear this tomorrow. There's going to be some changes to the skin. It could be some papules, telangiectasias. It can be sort of a progressive loss from the eyebrows going up to the temporal region. So this is something that if you biopsy it, there's a problem. If you transplant it, there's a problem. There's something called central centrifugal cicatricial alopecia, or CCCA. African Americans, there can be loss back here that could be CCCA. And then if you see the front, if they have something here and something here, I don't just assume that they had traction. There's about a 30% incidence there's something happening in the front, could be also a cicatricial or scarring alopecia. So don't just jump the transplant. If you've got any suspicion, go and biopsy or send it to a dermatologist. I work closely with dermatologists because I'm not a dermatologist, and I don't biopsy skin tissue for diagnoses. And so look for areas that just don't look right. The skin doesn't look right, and this is what's so helpful with dermoscopy. Nicole's going to have a dermoscopy station this afternoon. When you're starting to look for it, are the pores gone, or something else doesn't look right? So if, you know, the surgeons in the room can help the dermatologists be better surgeons. The dermatologists can help the surgeons be better dermatologists. And together, we work together to be more comprehensive. And I have this as a little promo. You're going to hear a little bit more of it later today, I think from Jim. As American Board of Hair Restoration Surgery, there's some information upstairs. You won't be eligible just to start, but it's something that it made me a better surgeon because I was a safer surgeon by being a better dermatologist, or at least knowing in whom not to operate. So if you have a pattern loss, it can be a diffuse in nature, okay, and that's divided into different Ludwig classifications. You've heard this before, I'm sure. And Elise Olson talks about this Christmas tree pattern, which it could be a variation of the diffuse one. So it's best if you can sort of comb down the middle and look, and you can sort of see this Christmas tree with the apex on the back, and it can either spare the hairline or it may involve the hairline. There's also just male pattern baldness just through the increase of androgens that are in the female as they get older. And DHEA is one of the big ones. So you want to look at chemistry, which brings me to chemistry. So you look at a full panel. On my website, I have female metabolic evaluation. You'll see it saves me a lot of breath. I have all that on there. So you look at thyroid functions. You look at an ESR, and if that ESR is positive, you probably want to look at ANA and look for any other problems. Iron is a big one. I just had a lady who I just asked a simple question, hey, how are your periods? And she says, oh, I'm losing a lot of blood from that, and it was timed with the onset of when her hair loss was. So I said, let's get an iron study. I mean, that's part of the whole workup. And so if you say, well, the history, Sam talked about pregnancy, talked about general anesthesia, but there's a larger history. And so that part of that is the history, and part of it is also a blood work to take a look at what's going on. And hormones, looking at DHEA, look at testosterone, look at estrogen, look at estradiol, and those things I don't deal with. Again, a lot of patients bring that laboratory back to me. I said, look, you need this managed through either someone that's an endocrinologist, an OBGYN, an anti-aging doctor, someone qualified to really get that work stabilized and optimized. So these are just simple categorical ways of looking at this, and I just give you this information. There's so many replacement meds. Viviscal, I use it really for patients that are, it's an oral supplement for about 6 months. If they're actively shedding, females, that's how I use it. I don't use it for general female loss. I don't use it generally for general other purposes. I use minoxidil and low-level laser therapy, and some of the new theory today is that female pattern loss is actually attributable to some kind of inflammatory component, so I like minoxidil with a steroid base to it. Upstairs I use the 82M. I don't have any financial affiliation to mention a product here. Spironolactone, I don't offer that. There's some things some medication, cross medication issues you got to check. Dermatologists do a great job with that. Finasteride, some of the earlier studies showed it did not work. The later studies show that it actually is effective. I would consider it possibly in a woman that is postmenopausal, because as you know, it's a teratogenic problem. And if this is not clearly established that it really does work, but I've anecdotally seen it does work in women, again, postmenopausal. So these are just different ways to treat it. So this is a lady that I tried minoxidil initially, and then I added the steroid component, and blam, she started to grow really, really well. From a surgical perspective, the things that you want to be careful with, this is a patient of mine that had significant shock loss in the back and the front. Fortunately, it came back, but that's something, when you're working with women, you almost want to tear your own hair out if you don't try to prevent these issues on a surgical level. So things that you want to do beforehand is minimize post-operative shock loss, which you're much more sensitive to. So I try to at least put them on 6 weeks of minoxidil, if not longer, educate them on the post-operative potential for this. And it can also, as you saw yesterday in Bob's lecture, can occur in men as well. Low-level laser therapy, anything to minimize it. And during the procedure, you want to decrease your epinephrine load. It's all in the textbook I wrote. I can give you that information separately as well, or just photocopy it upstairs at Kenny's, and then just don't buy it. I don't really care. Towel clamps, minimize all this, minimize tumescence, minimize dense packing of areas, and then afterwards, really supportive in nature is telling them they may need some camouflage products to make it thicker if it goes thinner. Tell them that before the surgery. So I always say the difference between education and excuse. In education, I tell you before, and excuse is, wait a second, doc, you never told me that. And then they may need a wig. I mean, that's very unlikely. But I go all the way to the end and say all this so that the patients are fully expecting any issues that could arise to the best of my capacity to explain it preoperatively. So always set up expectations and come up with the right indications to do a transplant, and those would be hair loss or simple female hairline lowering. And there's a couple ways to do that. It's beyond the scope of this lecture to go into details of talking about surgical advancements versus transplants. So the SDA area, you always want to be careful for females on the sides, because this is an area where they can have thinness. So unlike men, you got to be careful out here, well, men too, but women in particular, they can have a lot of thinning. So I usually, a lot of times, have to confine myself to the back. And in addition to that, the thing is picking the right patient. We talk about diffuse loss, diffuse unpatterned loss. I showed some of my students that yesterday in lab. That back here, some women have such poor caliber and thinness, they're not going to be a good transplant candidate. They've got diffuse loss everywhere. And so you've really got to pick your candidates very carefully. If they've got good donor area, great, but if their donor area is poor and they got diffuse loss, what you've got to do is create a strategy. So this is a simple strategy. You can't put hair everywhere, otherwise you're going to see no results. So I ask them how they part their hair. I focus on the part, if it's on the left, right, or the middle, so it's an L or a T, and I create and design it accordingly, okay? And this is what I call a dumbbell design, which is if they part in the middle, the central forelock hairline, and then it's sort of like a Christmas tree. If you look at this as like a modified Christmas tree, where sometimes you have a small crown loss in the back, and that's how I design it. You're going to see a live demo up there. These are my staff members that with no hair loss, just to show you the sort of cowlick whirl. Look at this pattern is different. Okay, it's a different shape. You know, look at non-balding female hairlines to understand it, just like I showed you on a non-balding male hairline. This is Amina's hairline. So look at, it's unusual. It's a different shape. It's not just this forward motion. And so this is a male hairline I showed you yesterday, and this is a female hairline, one of the female hairlines, and it's a different flow. I can show you that today because yesterday was about getting through the basics. And then when you just understand, on a male hairline versus a female hairline, there's a difference there. And this is just showing you how I create some central density areas, that sort of the dumbbell thing I talked about. And these are just some results. Female hairline lowering, okay? This is a male pattern baldness correction. This is a lady from a lot of steroid abuse as a bodybuilder, fixing that. This is just a frontal temporal recession. This is a lady that I did a transplant, then I added a little bit of scalp micropigmentation to enhance it. This is a traction alopecia. This is a transgender case. This is a lady that overplucked and has a bad looking tattoo eyebrow transplant. This is a very Ludwig III that I've improved but not entirely gotten rid of. This is a Ludwig II going to 3. This is a Christmas tree pattern I showed you earlier. And so I'll show you this pattern of design in about 30 minutes, okay? Live with 3D. So hopefully everyone got a 3D glasses. If you didn't, raise your hand, Marshall.